And Stacy has been gracious enough to be my co-host. So she's going to try to do the recording and then handle anything that might come into the chat room. Or I'm okay with you guys just unclicking or unmuting yourself and then speaking up, and then I'll just kind of jump right into it. Monica had asked me if I'd been to anything new and different this year that I wanted to share with infant toddler. And she said that, of course, you guys wanted some information on selective mutism, which I kind of covered last time. And then she also wanted me to go into stuttering. And I always get a lot of questions on stuttering. So I'm going to leave that as to the second part. So the first part of the presentation is going to be on something called ICF. So if you could do me a favor and in the chat room, put a thumbs up or a thumbs down if you've ever heard of ICF before. Give a couple of minutes for people to kind of jump into the chat room, or you can click off your video and give me a thumbs up, whatever's going to work for you. Thank you, Erin. There's one. Nobody else is thumb upping. So 1 out of 13 have heard of this before. Is that about right, guys? Okay, then I'm glad I'm going to go ahead and bring it up. I would like for you guys to at least hear about it. It's been around since 2001, so it's not something that's new, but it's something that our organization, as ASHA is concerned, has started doing trainings at the state level. So I thought it would be helpful if you guys could at least hear what it is from me, and then when you hear it again, you'll have a better understanding of it. Let me go ahead and jump to the share screen, and I will share my presentation with you. I thought I was going to be able to be there in person. Unfortunately, the pandemic is not going away, is it? It's staying with us. So here we go. I'm going to go ahead and try to minimize my picture there. So the International Classification of Functionality. And Erin, I know you did a thumbs up. Are you a PT, OT? Because a lot of my PTs and OTs have heard of this and have been working with this, whereas the speech paths maybe not so much yet anyway.
Erin's an SLP.
I'm an
Oh,
SLP.
good. Thank you, Erin. Where did you hear from Erin?
I went to grad school at KU, and they talked about it in every class.
Yeah, the newer grads would definitely have heard of it, and us older ones maybe not so much, but we should be aware of it, right? So let's see if it's not letting me move forward here. I'm getting a little nervous. There we go. So the International Classification of Functioning, Disability, and Health was developed by the World Health Organization to support its definition of health, the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So it's kind of a little paradigm shift in thought, okay? The information that I am going to share with you today came from ASHA as well as from the World Health Organization website. So I'm going to stop this share and get into another share to show you how you can find this information on your own, should you so desire. And then that way you don't feel like, oh gosh, I didn't get all that written down. You don't have to worry about getting it all written down. You can actually just go to the World Health Organization website and see for yourself. So this is the first part of that website, and it's, see if it'll let me back it up and go to the World Health Organization is a humongous website, but if you Google it, this comes up automatically, and then it has all of the different labels and everything right here in it. And the very first one that I went to was just the beginner's guide. Okay, and the beginner's guide kind of talks to you mainly about what the classification system is and how it's set up and how you can move forward using it within your organization. And the reason I want you guys to really hear about this is I honestly feel like it's going to come hitting the state levels pretty quickly, and it's going to start taking the place of some of these ICD codes that we currently use now, and we're going to have this paradigm shift in thought all around. Currently, I think 191 countries, which this website refers to them as states, are using this system, and I think it's only a matter of time before all of us do. Of course, the pandemic may interfere with that, but I wanted you to be able to see this so that you understood where this information is coming from. So World Health Organization, okay? So it looks at body, activities, and participation. The body is the function and the structure of the impairment, the activities, what limitations you might have with them, and the participation of that, what restrictions you might have. So it's not just looking at, are you sick? How sick are you? It's looking at what you can and cannot do functionally, which I think fits along very nicely with coaching, which is another reason why I thought I'd like to just at least mention it to you, let you guys hear it. So the main purpose was to provide a scientific basis for the understanding and the studying of health and health-related states, outcomes, and determinants, and to have kind of a commonality with language and a common way that we all can be dealing with this across disciplines and across domains. And it permits the comparison of data across countries by establishing this coding. Okay. What do schools and medical systems want to know? How are people doing in important life skills? Eating, having a conversation, following teacher directions, being safe, being mobile. And then, is progress being made towards those goals? And what can be done to change the environment to meet those goals? So it sounds a lot like primary coaching in those respects, which I think is awesome. But I also like that paradigm shift in thought where you're not necessarily looking at how sick is somebody, but how are they functioning within society. And then what will this information demonstrate? And this is where I think funding is going to eventually at some point get tied to things. So which facilities are demonstrating improvement in real life skills and which ones are not? Which professions are demonstrating improvements and which ones are not? And then how is that information being stored in an electronic data system? So by going to the ICF system, a lot of this information is going to be out for everyone to use, which if the schools are the ones demonstrating the progress, hopefully the schools will be the ones that can start to be receiving more funding to allow for that. So International Classification of Functionality, or ICF, in a nutshell. Get used to hearing that term. I went to Misha's online virtual training, and Asher was there talking about it. So I do feel like this is something that's going to be coming down the pike. So that was just a brief introduction of ICF. Okay. Any questions, comments, concerns? Nope. All right. Now we'll move on to our favorite topic that all speech paths love to hear about, stuttering. I get calls on this weekly. Weekly, I get calls on stuttering. I want to empower you so that you do not feel like you need to call me, but instead you feel like you can handle this if someone calls you and asks you about stuttering. So the first thing I want to go to, and I will share the screen with you, is some information that is out there and readily available to you as a professional. This first website is the Stuttering Foundation, and I think it's under something help. Something is not. If you would Google the Stuttering Foundation, this one comes up. And under this one, you can also look up here at the resources. And under the resources, you can go to brochures. And under the brochures, there are free ones that you can download that can talk, you can share with parents, you can help with teachers, 7 tips for talking with your child. I use a lot of these handouts on a regular basis, okay? And parents will have a lot of questions about stuttering. If you think your child is stuttering, explain the difference between normal speech development and stuttering in the young child. Notes to the teacher for the child who stutters at school. You can also talk with the daycare provider. These are great little handouts. Myths about stuttering. I'm just going to go ahead and open this one up real quick so that you can see it. These are all free. And they come in a nice, handy dandy, easy to look at and to share with your family's setup. Okay. There's also a lot of trainings that you can attend. So I'm going to back up a little bit from this one. I hope you guys are following this. Is my screen sharing okay, Stace?
It looks great, Kathy.
Thank you, my dear. If you wanted some other resources, There are trainings that you can go to with the Stuttering Foundation, which I have, and some of them are free. And then for virtual learning as well, there's newsletters, they have a library, they have books on stuttering. All of this is through the Stuttering Foundation, and I use this website a lot because there's so many free things on here. So remember that, the Stuttering Foundation. You too can have these same brochures for free. The next one I'm going to get into is our handy dandy ASHA website. And those of you who are not members of ASHA, I strongly encourage you to join. I know it is not a cheap organization to belong to, and that when you have a limited income, spending this kind of money to join ASHA is tough. But they have a plethora of information for us, and they do advocate for us. So this is their practice portal. And if you are a member, I recommend that you come here and you hang out for a while. This is just an idea of some of the topics that are in the practice portal and how you can use those within your everyday practice. So if I come in here and I click on fluency disorders, and this is in the ASHA portal in the ASHA practice portal, it will
Kathy,
come, yeah,
are you intending to share this screen with us?
you have not, you can't see it.
I do not see it yet.
Got it. Thanks, Stace. Keep me online, will you? Sometimes I just get to clicking. Can you see it yet?
Got it.
Okay, let me back it up so that you can actually see the practice portal. So in this practice portal on the ASHA website, it has your topics and the issues. And this is really a lot of information that is out there free if you're a member of ASHA to go ahead and look at and peruse. So I go into this portal a lot when I get a new child on my caseload that I'm not quite sure what's going on. I might go in here just to see what's out there, what new information I need. And then I feel like Ash has done a nice job of combining the research into this practice portal. So you can come down here and get this kind of quick overview. So would you like to know what articles are out there, what evidence is out there to support what you're trying to do? You can go right into the evidence maps to kind of see what that's like. And then it will list the articles for you if you decide to get the articles more in depth. One of the things that ASHA has not quite caught up with that other organizations have is if you belong to ASHA, you can sign up for which magazines or which research articles you want. Then if you want additional ones, you have to pay for them, which is, to me, I think you should pay one fee and then get everything for free, but ASHA doesn't agree with me yet. So we'll see if they catch up with me later. So it goes into fluency and it goes into cluttering. Some of the articles that I wanted to get more information on, I needed to pay for, which they're like 10 bucks a pop, and I didn't go there. So, but the practice portal is a wonderful resource that's available for you if you are a member of ASHA. Okay, so a lot of the information that you're going to see today on my Prezi comes from a combination of things. I'm going to go ahead and stop this share. Stacy, let me know if you don't see my next share, and get into my next presentation on fluency. Okay, you should have one that looks like a newspaper that says stuttering at the top.
Yep.
Okay, good. Thanks, Dave. This information came from the ASHA Journal and website, from the Stuttering Foundation, from a workshop that I attended, American Midwestern workshop that was up in Iowa, from Lisa Scott, who's a stuttering guru that I use a lot of her information. She does a lot of the cognitive behavioral therapy for stuttering. The Michael Palin Center used a lot of information from them. Scott Yaris for the preschool and the younger age. He's a phenomenal presenter. And if you ever get a chance to see if any of his trainings or online workshops, he's great. And I rely on him a lot for his information. Coleman with school-aged information, I used him. And then, of course, I love the University of Australia in Sydney and used some information from them. So those are my disclosures. I'm not receiving any additional funding to present for you today. I'm being paid by Greenbush to provide this training for you. And for those of you who don't know me, I work as a teletherapist now for Greenbush. Prior to that, I was a clinical instructor at KU Med for 21 years, retired from there. And while I was working at KU, I was also doing home visits with infant toddler. I also have worked for Shawnee Mission Public Schools, did PRN work for Children's Mercy Hospital, some of the adult rehab centers in the area, and also Oklahoma City Public Schools where I worked at a site called the Children's Place as their speech path of record, and trained grad students that funneled through me. And then now I decided after back surgery and knee surgery, I couldn't crawl around on the floor anymore. So I've been doing teletherapy for Greenbush for this would be my fourth complete year. So the definition of stuttering came right from the ASHA portal. It's the most common fluency disorder, and it's also the one that defined our profession. So speech language pathology started with stuttering. And so I think that's important to note. So we have more research out there on stuttering than any other disorder or issue that we deal with. So when you try to go through the research, it is like this mega volume of things that you're looking at. So I try to make it simple because I feel like even though it is the one that has the most body of evidence behind it to support it, I also feel like when we ask speech paths, what do you feel the most competent to work with and the least competent? Stuttering is always one of the least competent the SLPs feel like in being able to work with the individuals that stutter or that have these fluency issues. And I think a lot of that is because of the low prevalence of it. So we don't have it come up a lot. And when it does come up, we get this, oh my gosh, I haven't worked with this before. I need to hand it off to so-and-so who works with this a lot. And I want us to kind of take a little bit more ownership of it and be able to start working on it on our own without having that fear that we're going to mess something up. So it is that interruption in the flow of speaking characterized by repetition, sound prolongations, blocks, interjections, and revisions, which may affect the rate and the rhythm of speech. These disfluencies may be accompanied by some physical tension, some negative reactions, secondary behaviors or features, or avoidance of certain sounds, words, or speaking situations. I tried to dummy this down, not dummy it down, but younger it down for your population, for that younger child. One of the things that I'm really interested in is what's a predictor for persistent stuttering. So in our general population of children, 60 to 80% of children will stutter at some point during development. The stuttering may last for a very short period of time. It may last for several years. It may come and go. It may be very severe or it may be very mild. What percentage of that child, of those children who stutter, will persist and be a persistent stutterer and actually require some assistance in order to remediate? And these were some of the predictors for persistent stuttering. And this was taken from our journal, our own research by Walsh et al. In 2021, which I felt like it was a very good article. It's a positive family history, which is something we always ask for, does stuttering run in your family? Poor performance on standardized articulation or phonological assessments, a higher frequency of stuttering-like disfluencies during spontaneous speech, a lower accuracy on a non-word repetition task, are all associated with increased probability of the persistent person for stuttering, okay? Don't talk about the stuttering. It's the elephant in the room. I will do harm if I call attention to it. You will not. The stuttering will worsen. It will not. It will fix itself if I do nothing. Sometimes, yes, it does. Most stuttering goes away on its own. Yes, sometimes it does go away on its own. But it's okay to talk about it. In fact, it can alleviate the anxiety of a lot of children by talking about it because we demystify it. It's not this horrible thing that's happening to this little individual. Instead, it's something that we talk about. I see you're having a hard time talking today. There's a ton of different evaluation tools out there, and we've all used them. SSI, which, can you see me as well as seeing the screen, Stacy?
Yep, sure can.
Okay. So the SSI now has the SSI-4 that is out there. And when you look at what the SSI is, it's talking and measuring stuttering across 3 different situations: reading, speaking, and spontaneous. So what I try to do with my younger children, because they can't read for me, right? I can certainly catch it during speaking and spontaneous, or I can have them look at a picture and describe it for me. But I also go back and I have the parent record the child for me when they're having a really hard time so that I can get a feel for what the parent is seeing and hearing at home. So I look at kind of modifying the SSI-4 so that it will meet my needs to work with that very young child. So parent can record it, and I can do a spontaneous speech, and then I can try to confine the spontaneous language by having them talk about a picture. Okay. So I use a very simple approach that's good for young children and for parents, and I look at percent of stuttered syllable, what type of stuttering was exhibited, if I noted secondary characteristics or features, and then I look at a severity rating overall, from 0 being no stuttering to 10 being the worst I've ever heard. Okay. These are some other stuttering assessment tools that are out there that people use. And the most common ones that the schools use are the SSI. So if you come in with some of these other ones and you try to transition a child from, most of these aren't even normed until the child turns 5. Some of them are normed at 4. So just going with percent of stuttered syllable might be your best bet. When I'm talking about different treatment approaches, the good thing about being a speech path is that we can customize things on our own. The bad thing about that is that it takes a lot of time to be able to customize things on our own. So it's so much easier for someone to just say, here, try this, and we can just pick up something and just open it up and start using it. Stuttering is kind of a different ball game than just our tick or just language, in that it's going to change and alter over time in different situations. So I'm going to talk about these approaches and then note that I take bits and pieces of each one depending upon what the child is exhibiting and the I guess the comfort that the parent feels in being able to implement this when I'm not around. Okay. The lid comb is a common one out of Australia. The PCIT and the lid comb, I think, are pretty comparable somewhat. PCIT is parent-child interaction therapy, and it's kind of our mental health specialists have become certified in PCIT, and I think I saw Tracy's name on there, and she's PCIT certified. And this is where you take a parent and they're in the room playing with a child, and you teach the parent some skills to use, and then you talk to the parent through a microphone that the parent's wearing a little earbud in their ear, and you talk the parent through meeting some competencies at different levels. As the parent masters those competencies, you increase the ante. But it's very much of a coaching, parent-driven kind of model, and a lot of the research is coming out saying PCIT working with stuttering is also very successful. So that's why I mention it. The camper down is kind of the older model that I use for children that are kind of beyond just doing the lid comb. The CBT, or cognitive behavioral therapy with a stuttering focus, was kind of coined by Lisa Scott, and I have used that with a lot of my young adults. And then demand and capacity is the program that's been around for a long time, where you increase the demand as a person's able to and capable of being able to deal with that capacity. So I use the lid comb for my under 5 and in particular for my little tiny ones. It is a behavioral approach. It was developed in Sydney, Australia, in a suburb called Lidcombe. And it focuses on a behavioral approach to reduce or eliminate stuttering for children 5 and under. It has a 98% success rate, and I think that still is valid. It's changed over the years as more research has occurred, but basically there's 2 different stages to it. And because we have children with at birth to 3, and we're just getting them kind of as they're aging into 3 when we actually start thinking about stuttering, or we might start hearing it, because we know that the mean age for stuttering to start to occur in young children is 33 months. So that's just under that age 3, and usually around 4, that's when we'll start hearing it more. So for you guys, between that 30 months and 36 months before they age out of birth to 3, you might be getting these children. So on stage 1, the treatment phase is supervised by the SLP and includes weekly visits to the clinic, and I say and or home, with visits by the SLP where the speech path trains the parent and demonstrates verbal contingent stimulation, or VC. The parent provides verbal contingencies to their child first in this very structured conversational time designed for optimum fluency. And this has a combination of demand and capacity in it, because if you can get a child fluent at a 1-word utterance or a 2-word utterance, then you kind of increase that capacity and that demand on language as the parent and the child become more fluent in the situation. Language component is reduced until the child is fluent at the highest MLU possible. Then the parent is trained to provide verbal contingency within everyday conversation and routines. And then it moves to stage 2, which I'll be honest with you, with the young child, usually I'm in stage 1 for a very long time. Maintenance phase is stage 2, so usually that child will age out of the birth to 3 program before I've had time to go to a stage 2. But you want to keep the child, this is what's kind of bad about our programming too, you want to keep the child in services until you know that the fluency has maintained for at least 12 months post-treatment, which our healthcare system has transitions at 3 to 5 and then again at, early childhood into elementary school. So we have times when we change providers, and when those providers change, you could have this stoppage of service, which may be bad if the child hasn't generalized those skills to everyday conversation. Those verbal contingencies allow them, I talked about that, to train the parent for positive stutter-free speech. You need to have some stuttering because you need to be able to address it. If the child and the parent are playing together and everything's great and the child never stutters, then you can never teach the parent how to use stutter-free speech. So we can help the parent manage those variables by helping them to regulate their output using turn taking, word imitation, sentence completion, closed questioning, binary choice questions. The SLP helps to manage that output by finding how complex the child's language can be before stuttering starts to occur. This is individualized for each child. The parents are asked to rate their child's stuttering, and this is this severity rating that I kind of use all the time. So it's basically 0 is no stuttering, and they're saying 1 and 2s are no stuttering, up to 10, which is the most stuttering, is the most severe that's heard. Usually between that 4 and 5 look and 4 and 5 number, Anna Paula Mumi and I have talked a lot about having a better way of defining severity rating, and she's come up with a really nice scale that she uses that I've adapted at some point that's a little bit more descriptive. So the parent has a little bit more information to go on. So if I put a child down as a 4 to 5, they're still stuttering, everybody else would kind of hear that stutter and know that it was stuttering, but the message is still getting across. Whereas as the child gets up to that 7 or 8 or 9 or 10 level, the communication message typically is stopping and the child's recasting or just shutting down. So I want to make sure that the parent and I are on the same page on what the severity rating is. So every session I will ask the parent, so how has Joey's speech been this last week? What severity rating would you give him? And they tell me, and we've had a little play-based warm-up session, and I'll ask the parent, how do you think you would rate Joey's stuttering right now today? And then I would say, I rate it this way, and either we agree or we don't agree, but we want to make sure that we get to the point where we're both saying the same number so that we have a way of measuring this across time. And then these verbal contingencies are stutter-free speech and unambiguous stuttering. I have to teach the parent this, and this is something that as SLPs, we do this very naturally, but it's something that I have found for many of my parents is very hard to learn. So when I talk about praise, I need to give my parents specific examples. Wow, that was so smooth. Fantastic smooth talking. I'm loving your smooth speech. And then requesting self-evaluation for some of my older children that are able to do this. I might say, was that smooth? Were there any bumps there? Did that get stuck if they're having total blocks? And the acknowledgement, which is not necessarily praise, smooth talking, that was really smooth. So I'm trying to put some verbiage to what the child is doing that's on a kid-friendly level, but I'm also training the parent simultaneously when I'm working with them. In the unambiguous stuttering, I want to acknowledge a little bumpy, that got stuck, that was really long and stretchy, and then request that self-correction. Try that again without any bumps. Say that again and make it smooth for me. So during my sessions, I have the parent, I used to call this special talking time, and LidComp has kind of changed this quite a bit. There used to be a lot of videos on YouTube that you could go in and see what special talking time looked like, and all that has changed and been pulled from YouTube now. Now they want you to go through certification for the LidComp program. And you can go ahead and purchase the LidComp manual, which can talk about this, and it's been updated too. So keep that in mind that this is all out there and available to you. But I still kind of call it special talking time And I don't know if you guys would agree with this statement. So, correct me if you don't. As the pandemic has hit over the last year and a half, I'm seeing more stuttering. And I'm seeing it more with the anxiety that's coming with the child, where the child is scared and nervous. And so stuttering is coming out. And then they become more scared and nervous. And so then we're seeing more stuttering. And then the parents freaking out because the child's now stuttering. So now we're seeing even more stuttering. So it's kind of like this little cycle that I've been seeing. And I've talked to some professionals about it to see if they too are seeing this the same way. And they will come back to me and say, well, Kathy, we know that anxiety increases the child's stuttering, and that if they're anxious because of the pandemic or because now they're being exposed to a preschool class that they haven't seen one ever in their lifetime, that's going to increase their anxiety, so that might increase stuttering. So they're not necessarily seeing an increase in overall issues, but I'm getting more phone calls about it, which always makes me wonder, why am I getting more phone calls on this? So I don't know. I'm going to stop my share here real quick to see if I can get any information from you guys within the audience. If you're hearing and or seeing more stuttering within your caselets, you can unmute yourself. Nope.
Kathy, I can just say I haven't necessarily seen more cases of kids who are stuttering, but we're definitely seeing a lot more social emotional things that are going on, and of course, a lot more anxiety. That's just from what I've seen about, that I personally haven't seen any higher numbers of stuttering in the last year or two.
Well, good. That's encouraging. That's for sure. Anybody else?
I
No?
tend to agree with Stacy. In our population specifically, I don't know if I do have, family members whose kids are stuttering more. So I'm seeing that more in my own personal life, as you know, but I haven't seen it necessarily on my caseload with the little ones much yet.
Okay.
And I think it's pretty, I very rarely will we come across kids who are really truly not just having a little bit of a repetition of a first sound. I mean, most of the time it's pretty at that, by the time they're out, by the time we get them out of services, maybe they'll start to stutter. But we don't see a lot of that. At least I don't see a lot of stuttering where I am. We're just still trying to get, you know, vocalizations out sometimes.
Okay. Okay. Good. Anybody else? Hey, Tracy, now that I have you on, are you doing any PCIT?
Not in the true sense. I think in our primary coachings, I might talk about doing some of the pride skills, but in our particular situation, it's a little bit more challenging to do PCIT as it's intended.
Yeah. Is anybody else there at ITS certified with PCIT besides you?
I don't know that for sure. That might be a better question for Monica. The only other person that might be is the other social worker, Hannah, but I don't know that she is for sure.
Okay. I was just curious because it's a really good treatment modality, and you guys have people there. Tracy, who's certified, use her. Um, she does a phenomenal job. Okay, let me get back to the share the screen with our stuttering. Um, when I have worked with the young child who's stuttering within the home, and I asked the parent to do this special talking time, I've had some parents that have actually written out these verbal contingencies on a piece of paper, and they use that piece of paper while they have their special talking time. And during special talking time, it's one-on-one with that child. And so that one-on-one attention can sometimes decrease the stuttering because they've got the mom's attention. They don't have to worry about sharing it with anybody else. So we talk about what that can look like within a home environment. So if there are other children in the home, we might want to want to rethink how they're going to implement special talking time, because you don't want another child coming in and interrupting the session. And usually special talking time has been 10 to 15 minutes, which is a relatively short amount of time to spend. But again, like I say, 10 to 15 minutes once a day or twice a day makes a world of difference with these children. Once I get the child going during special talking time, Lidcombe has said you can go right into routines and you can have special talking time occur right during a routine. You don't need to pull it out separate. My family members, once they've started special talking time, want to keep it going because it's special time. And the kids will always say, "Is this special talking time?" They want to go back to it. So that one-on-one or time in has made a huge difference with the social emotional development of these young children. So keeping that in mind may be something that we have to work on fading. And then we want the parent again to keep track of the severity rating, the SR, during this time. And then I start to transition between structured and unstructured conversation. So if I've got a structured conversation, I'm dealing with known vocabulary. So the activity that I pick might be a puzzle, and there might be shapes and pieces to the puzzle with animals. And so I know what the name is. So I'm keeping it very structured. And I might be modeling what I want the child to say for me. And so I want dog, I want cow, and I'm trying to get to that little 3-word phrase that's a very carrier phrase that we can introduce other toys in as well. Once I get them fluent with that, then I'll start changing that up a little bit so it's more unstructured, and then fading to only unstructured. Sometimes that occurs simultaneously too, depending upon the needs of the parent and the needs of the child. When I move into stage 2, when severity ratings are 1s and 2s and they're consistent for several weeks, then I go ahead and I start to move into stage 2, which is to fade verbal contingency. Lidcombe has said when you start to do that, you can have relapse occur. And that's when I like to kind of go back and look at this percent of stuttered syllable as a criteria to check on whether or not I should go back in to have more structured visits, or if I can keep that in an unstructured setting. We're not going to have clinic visits on a home basis, but keeping that in mind that you can go from the unstructured to the structure. And performance contingence maintenance, I want to make sure that I have an increasing period of time where stutter-free speech. So if, yes, we haven't had any stuttering for several weeks, sometimes you can even just do a phone call. Do you need me to come back in? What's the severity rating been like? And then I want to make sure I at least check in person once a month, because what a parent has been telling me, they're not seeing any stuttering, and then I come in and I might be a trigger to kind of start the stuttering again because they remember stuttering and having special talking time when I first started. So you want to make sure that none of those kind of triggers are going to happen and have the stuttering kind of come back. So make sure you still do an in-person visit with the child as well. And then I talked a little bit about parent-child interaction therapy. Our Journal of Speech, Language, and Hearing Research in June of 2008, Millard and Cook studied PCIT and found that PCIT is a very effective treatment for young children who stutter. The results indicated that in 4 of the 6 children that were in the study, PCIT greatly reduced stuttering within just 6 sessions of clinic-based and 6 sessions of parent-led home-based therapy. So again, I think PCIT and home-based intervention and Lidcombe are very similar, except that PCIT has a real regimented, scaled way of saying a parent has met competencies before you move to a next level, whereas with the Lidcombe, we're looking more for stutter-free speech before we increase the demands for language. And these are some of these similarities that I talked about. Familiar terms that you should keep telling yourself that you're trained to do is responsiveness. Those of us who've been through responsive teaching, learning through play, play-based interaction, parent competencies and confidencies. All of these are important that I think as speech paths and as home interventionists, we're very good at. You cannot implement PCIT without proper training, but it's important to note that there's a lot of value to that therapeutic model and that it is very similar to the I do talk to the children a lot about anatomy and physiology and about sounds and I may have a different verbiage that I use with children. The young child versus the older child. A plosive might be a stop sound. Oh, I stop that sound at my lips. Put your finger on your lips. Where are your lips? Oh, I stop that sound with my tongue. Put your finger on your tongue. So I want them to be aware of what their articulators are. And if I have a child who's totally blocking, I want them to be aware of where that sound is stopping at. And I'll refer to fricatives as my long sounds. Oh, that's a long sound. Listen to this one. That sound just keeps going and going right through my teeth. Can you make that sound too? And then I talk about the respiratory system and how we breathe. I talk about being able to feel a sound, and not feel a sound, so that they can know when they keep their voice on and when their voice is off. As the child gets older, I use more specific terms. And for my adults and young adults, I'm going right there. And then Lisa Scott kind of came in with a cognitive behavioral therapy, and this is for the much older child. But I want you to be aware of what that term is. I'm not going to spend a lot of time on it just because you don't deal with these older children. You deal with the little younger ones. And this is all about the cognitive behavioral stuttering focus. So I have a complete sheet of who supports that individual. I have a worry dial. Can we turn that worry dial up? Can we turn that worry dial down? Sometimes with my children that are having a lot of anxiety, I will talk about that. Ooh, you look really worried today. You look really nervous today. Let's see if we can take a deep breath and turn that worry down. And then I will have coping skills and coping cards for those individuals. And they usually will make their own up. So this is that who supports me. And that's what the worry dial looks like, ways that I can turn that worry dial down. And then I get this question a lot from parents. Why is it so hard to help individuals achieve speech change? And that demand on attention, where we have to really focus and think about what it is we're saying. And when you think about the dynamics involved in language and in speech, being able to suddenly think about not only what I'm saying, but how I'm saying it, and then being able to try to change when you're in the moment is very hard. And then it can be very painful if it brings up painful thoughts and feelings. Some of those painful things are not being able to say their name, not being able to give an answer in class, not being able to tell a teacher they had to go potty so they wet their pants, not being picked for a play because they stutter, eating alone because they're afraid to talk with other people, not telling a joke or telling the answer to a joke because they're afraid it's going to take too long, and just saying, I don't know, when they actually do know because they're afraid they're going to stutter and it's going to be too painful for them. Someone asking me why I don't talk right. That's another very painful experience. I have parents that have told me, I need you to come out because Joey says they can't talk anymore, and they hit themselves when they're not able to talk. And I had some video of a little one who was actually trying to hit himself to get his speech unstuck. He wasn't hitting himself because he was mad, but because he thought that that would unstuck himself or unstick the speech. And the parent talked a lot about how this abusive behavior started because things were just getting stuck and he just put his head down or he'd start to hit himself. So it took quite a bit of intervention. So even though that child may not have been a persistent stutterer, it would certainly warrant us going in and working with that family so the child wouldn't continually hit themselves. Some of the traditional strategies that I've talked with families, if I get a child that is totally shut down and not talking at all, I talk about stretching the sound. Sometimes I use things like rubber bands. Sometimes I use things like their finger across the board. Sometimes I'll talk to them about stopping or pulling out and then starting again. Talk a lot about visualizing the next sound if they're old enough to understand that. And that whole light articulatory contact is something that I say, let's say that real softly. Let's say that real gently. Blocks, sometimes having that silent H. There have been some research coming out saying that that really doesn't have a big impact, but I have had my clients that have huge blocks that say it at least opens them up and gets things started. So be aware that there's some research out there that says that it has not been helpful for some clients. the prolongations that pull out or force a prolongation to push yourself through it. Many of my adult clients or young adults say that they like to just push through the stuttered moment. So being able to pull out and start again, they feel is punitive and repeating. So they don't want to do it. So when I say, can you think about the sound that you're prolonging and just prolong it a little bit more because you're gaining control of that prolongation at that time? So we work on that quite a bit. An individual who stutters has a really good way of manipulating the therapy session so that they don't have to work a lot during it. So it's important to kind of keep that in mind as you're working with these young children and the parents. If the parents are feeling insecure about how to intervene with the child, they might get you going on another topic. So how can you pull the parent back to verbal contingencies and what you want them to do when they work with the child so that you can build their capacity to understand and build their competency and confidence so that you're not just kind of spinning your wheels during those sessions. As with all of you, right when I'm getting ready to leave the house, that's when the parent will have all these questions. So I'm trying to constantly ask them during the session, do you have any questions? Is there anything I can help you with? See if they'll open up a little bit more until I not wait till I get ready to leave. This I deal probably more with an older child, that behavioral activation, when an individual begins or needs to begin doing something rather than generalize. I need new thoughts to take the place of the old ones with an end goal in mind. So that's when I'll do these experiments with the child that's older, not so much the one who's little. Sometimes with the little ones, I deal so much with other family members that may not necessarily be helpful. So a grandparent, an aunt, somebody who has said, well, just tell them not to do it. And the mother would say, well, if that would work, I would try that. And so then the grandparent will try to intervene, and when they're babysitting, and they can kind of undo some of the things that we did during our session. So keep in mind that when you come in and you might see an increase in started behavior, make sure you kind of probe a little bit of that with the parent. Um, where has Joey been this week? Has anything new or different happened? And see if they're able to open up and kind of talk to you about it. I've had some pretty interfering other family members, and sometimes dads cannot be as empathetic to it. We do know that stuttering does run 4 times greater in boys than girls, and that statistic has pretty much remained the same. The prevalency levels change anywhere from less than 1% to 7%, depending upon which study you look at. I typically see it in about 2%. I say this over and over again, nothing we should do should ever be punitive. Have another person in the individual's life be their partner on this journey. Many times it is the mother, but sometimes it can be somebody else in the family. Transfer the fluency help to this person. We are not the only one who can help but we need to cross-train others and role release and empower other people, because the child would only be with us once a week, where they're going to be with those other people 24/7. I tried these exposures. If I get a little one and they're now becoming more fluent in the unstructured settings, I will go ahead and look at making sure that carries over to other places and other situations. So are they stuttering at daycare, or is daycare better? Sometimes the daycare providers never heard the stutter to begin with. Sometimes the daycare provider is the one that why we got called in. So I want to make sure that the child is able to demonstrate the stutter-free speech across environments and across people. Okay. With my CBT, I might be using this as a behavioral experiment in exposures. Counseling needs to look at the whole person. Negative feelings towards stuttering, avoidance should be targets for intervention. I need to look at that eye contact, turn taking, topic maintenance, initiation. Stuttering can co-occur with many other disabilities. All of this can be a part of the pragmatic function of a child. Video feedback and self-evaluation can be used for the older child, but having the parent video for me so that I can see what the parent sees is also very helpful. If I come into the home and the child's never stuttering, and the parent says, oh, they stutter all the time, I'm going to want that mother to video that for me so that I can see it next time I come, so that I can see what she sees. And then if what I think she's seeing is not as severe as what I'm seeing, I want to talk about that, so that I want the parent to not be so upset, because if the parent's upset, the child's going to feel that. So I want to make sure that I'm there to support the family and not just the little one who might be struggling or may not be struggling. As speech paths, there's a lot of training for us, especially on the different stuttering websites on counseling, to listen, encourage, support, reflect, empower, and then plan forward, providing a safe, judgment-free environment, discuss what's working, why is that working, what's not working, why do they feel like it's not working, what are the barriers to success that need to be addressed, and then frequent contact with our support person. With my older individuals, I do talk a lot about going to a mental health specialist, especially if I have a person who has such severe negative thoughts that I feel like it's above my level of expertise. And when it is, I want to make sure that that individual has somebody to be able to talk to. And then I want to be able to work with that person. So I want to make sure that we sign releases and we're working together. This behavioral activation, which is some of this CBT part, is the emphasis on doing something. And I will kind of bring this to a parent coaching model. So the emphasis is on doing something, not what you're not doing. Or let's change it and do it slightly different. And can we accomplish that through that task analysis, which I think all of us as early interventionists are very good at doing? No change is too small or insignificant. So I want to make the smallest change without impacting the child's day that still helps them become more fluent. So if that can happen during a routine, then I wouldn't necessarily start with special talking time. If I can't get that to happen within a routine like mealtime or bath time, then I might have to pull it out and go with just special talking time. So I'm going to modify what I'm doing according to what I need to have the parent do and what they're capable of. And then the cycles of change, that pre-contemplation. Sometimes parents look at you as the speech path and you're going to fix the child. But we know that with coaching and with that birth to 3 population, it's the parent that needs to take ownership of that. So the parent has to come to the realization that that they're the ones that are going to have to activate that change. And that's kind of a hard leap for some parents who have come into therapy under the mode of, you're going to fix this for me. And then when they realize you're not, sometimes they will a therapist jump and try to find other therapists, somebody who will fix their child. And there are plenty of ones out there privately who will take their money and try to work with their child. But coming back to the parent with the question of who's more vested in your child, you are as the parent. Nobody cares more about your child or loves your child or knows your child more than you. So who should I be working with? But you're the one that I want to be able to work with your child kind of when nobody else is around. So if you get a child talking during a therapy session one-on-one in a clinic room, how's that going to generalize into what you're doing every day? Because you're going to have to work on that generalization component. But if you teach the parent, then you can kind of skip that because they'll be generalizing as they go. So, and then the contemplative, the preparation, then the actual taking the action, the maintenance, and then relapse. We all know relapse is a part of that cycle of change, and everyone will relapse because, well, they were fine, so I didn't have to worry about doing it anymore. And now they're not fine, so what do I need to do? So talking about what was the plan we first had in place, and can we go back to that? These are the resources that I've talked to you about. The National Stuttering Association also has a really good resource, stutteringcenter.org. I think it's Scott Yaris's website, which I think is a really good program. And then, of course, the Sydney, Australia website is big and good with LidCommon as well as the Camper Down program. And then we get into questions. I'm going to go ahead and stop the share. Dead silence, cricket, cricket. You guys are tired of trainings, aren't you? No questions? Do you all feel like you can pick up the torch and take off on your own if you need to? Thumbs up? Yes.
I have a question, Kathy. So when the parents do give you a call, what's kind of the way you kind of tackle what they need to do next? I saw that you gave us those list of little criteria for
the case history is where I start.
Okay.
So do they have any of those warning signs that would tell me, or red flags that would tell me they might be a persistent stutterer? And if they
Mhm.
do, then I want to find out what those are. So I'll ask, does stuttering run in your family? How frequently do you feel like Joey does this throughout his day? Is Joey aware that he is stuttering? Have you talked to him about it? If so, what did that look like? So I do start with a pretty strong case history, and then I ask the parent to tell me what kind of stuttering that they hear, and then I look to see, are there any of those secondary features or
Okay.
characteristics that are being used. And once the parent has kind of started talking to me about that, then we can kind of ease forward as to what I need to share with them next.
Okay.
Does that make
Okay.
sense?
So what if they, yeah. And so if they say, their child, let's say 4, let's just say, and they're, they don't have family history, but they're basically, disfluent on every single syllable of every sentence, then you're suggesting you're sending them the brochures that you had talked about, and having
I
them start
am.
to talk about it on their own. When do you
I am.
decide? Okay, go ahead.
Sometimes I think those families are just scared
Uh-huh.
because
Yeah.
they want to make sure that they're doing everything that they need to be doing for their child, and so they want some validation for that. And if I
Mhm.
have a child who's been inconsistent with the stuttering, and they've had long periods of time where they are very fluent and there is no stuttering, that to me is a very good prognostic indicator that
Mhm.
what we're dealing with is pretty typical. And so I'll kind of back off things a lot unless I get to a point where the child is self-abusive, hitting themselves because the words are
Mhm.
getting stuck or they feel like they can't talk and they're very aware of it. Then I would probably want to do a home visit at that point to kind of take a look see at what's going on. If the child is not aware of the stuttering and the parent feels like everything is really inconsistent, good some days, bad other days, I'd probably go with the wait and see, get down on the child's level, make sure that you're listening to what they have to say, give them plenty of time to talk, don't interrupt them before I would start any direct intervention. But if I have a parent consistently calling me, then I think that that's time for me to become more involved professionally at that point
Mhm. Okay.
because it's not going away. So
Okay,
the
that's great.
parents, even though the stuttering might be going away, the parents' anxiety about the stuttering is not going away. So I probably
Right.
need to be addressing that parent more directly.
Right. Right. Okay. Because I think my initial kind of reaction is, oh, I don't really want to take that on because I know I don't want to make it worse. That's kind of why I would
You're not going to make it
typically send
worse.
them to you. I know, but I'm afraid I'm going to give them bad advice, and they're going to, you know, I I guess the main thing that you can attend to it, but you just don't want to be punitive about it because
Right.
I was kind of, I know you've talked about it before, but I have, this thought like, oh, if you bring too much attention to it, that it's gonna, but the kids already know that they're stuttering, and it's something maybe talking about it can help ease their anxiety about it. So that's super
Okay.
awesome. Thanks.
My pleasure. Okay, Stace, I think that's it. Anybody else have any questions? Not that I want to cut you off, but okay. Thank you, everybody. It's been my pleasure. Hope you guys have a good rest of your day.
You too,
Thanks,
Kathy. Thanks so
Kathy.
much for
Thanks,
joining
guys.
us again, as always.
Bye.
Bye bye.